Cardiology, IM evaluation of chest pain because high risk of false plus VE result. To consider coronary angiography. Evaluation of chest pain in emergency department plus O2. Aspirin is given before heparin in ACS. Aspirin significantly reduce the rate of MI, stroke, and overall mortality in ACS. Atypical symptoms in acute coronary syndrome. Women, elderly and PTS with diabetes are more likely to develop atypical symptoms. Up to 20% do not report chest pain at the time of presentation. Rightward arrow. Delay diagnosis and under treatment medication to withhold prior to cardiac stress testing. These medicines should be continued with those with known CAD to assess efficacy of antianginal therapy. Decision to withhold meds should also be carefully tailored to the individuals to minimize the risk of rebound HTN or arrhythmias. Differential diagnosis of chest pain. Features suggesting esophageal disease, prolonged pain lasting 1 hour, postprandial symptoms, associated heartburn, dysphagia and relief of pain by entire flux therapy. Treatment for stable chronic angina. Variant/Prinzmetal angina, NGT is vasodilator arteriodilator. Their primary anti-ischemic effect is mediated by systemic vasodilation and downward arrow in preload. This, in turn, leads to a reduction in left ventricular and diastolic volume and systolic wall stress, resulting in decreased myocardial oxygen demand. Although nitrates act as coronary vasodilators, via direct relaxation of coronary vascular smooth muscle cells, the beneficial effect of this mechanism is uncertain. Common in young women, greatest risk factor is smoking. Atherosclerotic risk factors usually absent, episodes common at night, 12 a.m. to 8 a.m., after exercise, hyperventilation, emotional stress, cold exposure, or cocaine use, transient ST elevation and then return to baseline, unlike ST depression in unstable angina and longer duration of ST elevation in MI, RX, CCB or nitrates. Prinzmetal's angina is caused by temporary spasm of the coronary arteries, as opposed to atherosclerotic narrowing which is seen in myocardial infarction. Variant angina is associated with other vasospastic disorders, such as Raynaud's phenomenon and migraine headaches. Myocardial infarction. Right ventricular MI, seen in 30 to 50% PTS with acute inferior wall MI due to occlusion of RCA proximal to origin of RV branches. ST segment elevation in inferior leads to 3 and AVF. Transient bradycardia or AV block can also occur with acute inferior wall MI due to enhanced vagal tone. JVD, Kussmaul sign, and clear lungs are signs of RHF. Massive pulmonary embolism can present similar to RV infarction. However, ECG will show tachycardia, non-specific ST segment or T-wave changes, rather than ST segment elevation, new onset RBBB or S1Q3T3 pattern. Dx of RVMI is confirmed with /=1 mm ST segment elevation in right precordial leads V4R, V6R. RV failure leads to DEC. Preload and resultant hypotension, worsen with nitroglycerin, diuretics, and opioids. That DEC. Preload, avoid. Drugs that slow HR like beta blockers and that DEC. Contractility like CCB should be used with caution. In addition to standard MI therapy, such PTS, without pulmonary congestion, low/normal JVP, are typically treated with high-flow 4 fluids, isotonic saline, to improve RV preload and facilitate left ventricular filling. 4 fluids are less likely to help in these PTS if JVP is elevated. Inferior and posterior wall MI, RCA in ECG. RCA also supplies AV node and hence, occlusion can cause AV block. Inferior wall MI is most commonly associated with sinus bradycardia due to increased vagal tone in first 24 hours after infarction and DEC. RCA blood flow to SA node. Also lead RV infarction/dysfunction. Rightward arrow hypotension. Acute inferior wall MI rightward arrow papillary muscle dysfunction. Rupture can occur in 2 to 7 days post-MI. Rightward arrow acute MR rightward arrow excessive diastolic volume overload rightward arrow elevated left ventricular end diastolic pressure, LVID, LV. Filling pressure, rightward arrow reflected back to left atrium rightward arrow pulmonary circulation rightward arrow S/S of congestive heart failure. Unlike chronic MR, acute MR does not cause any significant change if left atrial or ventricular size and/or compliance, ST elevation in lead I, AVL and V2, V6 and reciprocal depression in 2, 3, and AVF rightward arrow acute anterolateral MI due to occlusion of LAD supply anterior walls of left ventricle and ant. 2/3 of septum and hence, occlusion can cause second-degree AV block. Post-MI complications. Murmur. Heard at left lower border usually distant heart sounds. Ventricular arrhythmias, including ventricular premature beats, non-sustained or sustained ventricular tachy, and ventricular fibrillation quite common in immediate post-MI period. Ventricular fibrillation, most common cause of sudden cardiac arrest in setting of acute MI, more than 50% occur within first hour of symptom onset. Re-entry is the predominant mechanism responsible, though underlying mechanism depends on time elapsed since onset of MI. Arrhythmia occurring within 10 minutes of coronary occlusion immediate or phase 1 of ventricular arrhythmia MOA, reentrant arrhythmia, arrhythmia occurring within 10 to 60 minutes after acute infarction delayed or phase 1b arrhythmia MOA, abnormal automaticity. Ventricular free wall rupture. Majority of ventricular free wall rupture occur after anterior wall MI. Abrupt LV rupture leads to hemopericardium and eventually cardiac tamponade. Rightward arrow compresses left ventricle and decrease stroke volume. Rightward arrow compensatory sinus tachycardia. Severe mechanical compromise can rapidly progress to pulseless electrical activity, P, with ECG showing low voltage electrical activity. LV free wall rupture should be suspected in cases of recent MI and no signs of heart failure. Rapid diagnosis with echo, supportive care, pericardiocentesis and possible surgical repair are needed to save PT life. Ventricular aneurysm, hallmark ECG findings, persistent ST segment elevation after recent MI and deep Q waves in same leads. Usually, ST segment elevations resolve within a few weeks of an MI, but here it does not. Large VA can lead to progressive left ventricular enlargement leading to heart failure, refractory angina, ventricular arrhythmia, and mural thrombus leading to systemic embolization. Progressive LV enlargement can lead to MR, confirmed with echo showing dyskinetic wall motion of a portion of left ventricle. Papillary muscle rupture, life-threatening complication due to surrounding tissue necrosis. Rightward arrow severe acute MR. Rightward arrow hypotension and pulmonary edema. Dressler syndrome, can occur weeks after MI. NSAIDs are the mainstay of therapy and corticosteroids can be used in refractory cases or when NSAIDs are contraindicated. Anticoagulants should be avoided to prevent development of hemorrhagic pericardial effusion. Management of STEMI. Beta blockers should not be used in case of pulmonary edema. I.e. Acute decompensation, morphine is anxiolytic plus downward arrow pre-load. Should not be routinely used co of increased mortality, ischemic heart failure 2 degrees to MI. Rightward arrow acute pulmonary edema, flash pulmonary edema, stent thrombosis is a potentially fatal complication of coronary artery stenting and long-term dual antiplatelet therapy with aspirin and platelet P2Y12 receptor blockers is recommended to reduce this complication. Premature discontinuation of these meds is the strongest predictor of stent thrombosis. Within first 12 months screening and counseling regarding medicine compliance is needed. Aspirin in full dose to be chewed for quick action. Morphine can also be given for pain control if nitroglycerin insufficient. Nitroglycerin mainly cause dilation of capacitance vessels, veins, rightward arrow deck. Preload rightward arrow deck. Heart size rightward arrow deck. O2 demand. Also dilate arteries I.E.dec. After load, but this is not significant, prompt coronary reperfusion with PCI or fibrinolytic therapy restores flow, limit myocardial damage and reduce mortality. Rightward arrow. Most important intervention to improve long-term prognosis. Current guidelines for PCI for PTS with acute STEMI within 12 hours of symptom onset and within 90 minutes from first medical contact to device time at PCI, capable facility within 120 minutes from first medical contact to device time at a non-PCI capable facility. 2. Allow time for transport to a PCI capable facility. PCI has better survival and less risk of MI and stroke as compared to fibrinolytic therapy, which can be done if within 12 hours of symptom onset who cannot undergo PCI. E.G. PCI is NT available within the recommended time frame. If fibrinolytics are being used, then door to needle time should ideally be 30 minutes. Management of NSTEMI. Revascularization with drug-eluting stent placement. These are the drugs given after discharge of MIPTS, long-term therapy for 2 prevention. 1. Dual antiplatelet therapy, DAPT, with aspirin and P2Y12 receptor blockers, e.g. clopidogrel, prasugrel, ticagrelor. Rightward arrow. Significant reduction of recurrent MI and cardiovascular death compared to aspirin alone. Long-term DAPT reduce stent thrombosis. Recommended for at least 12 months in all points following drug-eluting stent. 2. Beta blockers. 3. ACEI or ARB4. Statins. 5. Aldosterone antagonist. If F/equals 40% with HF symptoms or DMACEI should be started in all PTS with MI within 24 hours to prevent remodeling of heart. I.E. Dilation of left ventricle with thinning of ventricular wall, which takes weeks to months. Apazaban, factor XA inhibitor, is used for anticoagulation in non-valvular atrial fibrillation and for management of DVT and pulmonary embolism. Red QID 9648. Causes of heart failure with preserved left ventricular function, diastolic dysfunction, common cause of decompensated congestive heart failure. CHF signs with normal or near normal F, 50%. Exacerbated by loss of atrial kick. Associated with S4. S4 is an indicator of a stiff left ventricle. Beriberi, Paget disease, and arteriovenous fistulas. Hemodynamics in heart failure. RAAS effects. 1. Vasoconstriction of both the afferent and efferent glomerular arterioles. Rightward arrow. Decrease in renal blood flow. 2. Vasoconstriction of efferent renal arterioles. Rightward arrow. Inc. Interglomerular pressure. Rightward arrow. Maintain GFR. 3. Sodium resorption in the proximal tubules and increased secretion of aldosterone, decreased sodium delivery to the distal tubule. RAASADH. Norepinephrine cardiac index equals CO/body surface area. Cardiac index is also reduced in heart failure. Acute decompensated heart failure. Most common cause, LV systolic or diastolic dysfunction with or without additional cardiac dis. E.G. Acute MI, arrhythmia, acute severe MR or AR, pulm. Edema can also occur in severe HTN, renal artery stenosis or severe renal dis. With fluid overload, nitroglycerin is of special benefit in PTS with MR or symptomatic myocardial ischemia. Cardioselective beta blockers contraindicated in acute case. Elevated BNP and S3 gallop correlate with increased cardiac filling pressures and noted in PTS with CHF due to left ventricular systolic dysfunction. Pro-BNP produce active BNP and N-terminal pro-BNP. Both of them correlate with severity of left ventricular systolic dysfunction. BNP has very high negative predictive value, and if negative test result, the look for other causes. Peripheral edema also does not correlate with BNP as much as S3. Poor prognostic factors in systolic heart failure. Hyponatremia in PTS with CHR usually parallel the severity of heart failure and is independent predictor of adverse clinical outcomes. downward arrow perfusion at pressure at baroreceptors and renal afferent arterioles, rightward arrow neurohumoral activation and renin, NE, and ADH secretion, rightward arrow AD promote free water absorption, renin and NE upward arrow proximal sodium and water absorption and limit water delivery to distal tubule, rightward arrow free water retention and dilutional hyponatremia, restrict water intake, ACEI, and loop diuretics. Initial therapy in hyponatremia in CHFPT. Salt tablets can be given in SIAD but not in edematous state. Exacerbation of congestive heart failure, CHF, RF, HTN, smoking, CAD-PE, B-bacillar crackles, decreased breath sounds, due to pleural effusion, some wheezing, cardiac asthma. 0 ABGs, hypoxia, hypocapnia, and respiratory alkalosis. S3, upward arrow BNPQID, 4570 respiratory. Cocaine-induced steaming. Associated with pupil dilation and blood-crusted nose, cocaine also enhanced thrombus formation by enhancing platelet activation and aggregation. Benzodiazepines downward arrow myocardial oxygen demand and alleviate cardiovascular symptoms as well. Given in 4 form along with supplemental oxygen, alpha blockers like phentolamine can also help reduce vasospasm, aortic valve endocarditis and AV block. When AR is due to valvular disease, rightward arrow murmur heard along left sternal border, 3rd and 4th intercostal space. When AR is Cox of aortic root dilation, rightward arrow murmur best heard at right sternal border, if new AV block is present in case of 4 drug user along with AR. Murmur, suspect paravalvular abscess extending into adjacent cardiac conduction pathway, conduction defects not common in tricuspid endocarditis, occurs in 30 to 40% PTS of IE. Aside from aortic valve involvement, IVDU is also independent predictor of periannular extension of infection. Dilated cardiomyopathy, echocardiogram with reduced ejection fraction, progressive heart failure, S3 restrictive cardiomyopathy, small sign on physical exam, ECG with low voltages, S3. Hypertrophic cardiomyopathy, echocardiogram with normal ejection fraction, S4 gallop on physical exam, hypertrophic cardiomyopathy. HCM common in African American population and is autosomal dominant. 2. Most common mutations responsible for about 70% cases are 1. Cardiac myosin binding protein C gene, 2. Cardiac beta myosin heavy chain gene, PT. May be asymptomatic or present with dyspnea on exertion, chest pain, palpitations, or pre-syncope/syncope. Up to half of the PTS who die suddenly from HCM don't have any prior symptoms. Myocardial hypertrophy and fibrosis peak during puberty and exertion can precipitate acute LV outflow tract obstruction or ventricular fib. Physical exam, carotid pulse with dual upstroke due to mid-systolic obstruction during cardiac contraction. HCM with significant LVOT obstruction causes systolic ejection murmur. Murmur along left sternal border with a strong apical impulse. All athletes should undergo pre-participation evaluation before being cleared for sports as it is preventable. FH of sudden unexplained death should prompt echo and ECG, and PT should refrain from exertion till nothing is found on these tests. Athletes without prior cardiac condition can develop fatal ventricular fib after sudden blunt chest trauma, also known as commotio cordis. Restrictive cardiomyopathy, less common than dilated and HCM, caused by infiltrative dis. Sarcoidosis, amyloidosis, storage dis. Hemochromatosis, endomyocardial fibrosis, or it may be idiopathic. Hemochromatosis is the only one which is reversible with treatment I.E. Phlebotomy, primarily caused diastolic dysfunction with minimally affected systolic function. Left ventricular volume is normal and wall thickness is either normal or symmetrically thickened, distinguishes from HCM. Right heart failure signs are more prominent but can also cause signs of left HF. Amyloidosis. Predominantly diastolic dysfunction. PT may develop syncope or presyncope due to conduction abnormalities, ECG, low voltage, echo, increased ventricular wall thickness with normal ventricular cavity dimensions, ESP in OTS without HTN, tissue biopsy, e.g. abdominal fat pad, bone marrow, rectum, kidney, endomyocardial biopsy, can confirm diagnosis by showing amyloid deposits. Sarcoidosis can cause granulomatous infiltration of myocardium and HF with both systolic and / or diastolic dysfunction, affects young adults. Involve lungs, skin, eyes. Causes dilated cardiomyopathy, as a result of toxic, alcohol, metabolic, hemochromatosis, or infectious agents, viral myocarditis, H/O recent upper RESP. Tract infection viral, most common cause, Coxsackie virus B myocarditis, other viral causes, parvovirus B19, HHV6, adenovirus and enterovirus, MOA, direct viral damage and as a result of humoral or cellular immune responses to persistent viral infections, DX, echo shows dilated ventricles with diffuse hypokinesia resulting in a low ejection fraction, I.E. Systolic dysfunction, RX, largely supportive, mainly management of CHF symptoms. Cardiac tamponade vs dilated cardiomyopathy. In tamponade there will be clear lung fields, whereas in dilated cardiomyopathy basilar crackles will be heard with pulmonary venous congestion on CXR. S3 will be heard in DCM. Cardiac tamponade can be idiopathic, usually viral, can be bacterial, fungal, neoplastic, primary or metastatic, post-MI, trauma, uremia, autoimmune, hypothyroidism. Enlarged globular cardiac silhouette, water bottle heart shape. Mainly affects right side of heart, inability to palpate point of maximal impulse. Beat-to-beat variation in QRS amplitude and axis. Electrical alternans with sinus tachy is highly specific for large pericardial effusion. Rightward arrow emergency pericardiocentesis. Auscultation of heart sounds. S4 is heard in acute MI because of ischemia-induced myocardial dysfunction. Key distinguishing feature of benign vs pathological murmur is change in intensity with change in position. Position that deck. Venous return to heart, deck intensity of innocent murmur. Management, reassurance and observation in benign murmurs. Hepatojugular reflux, used to differentiate BTW cardiac and liver dis. Elevation of JVP 3 cm during abdominal compression, sign of failing right heart. Common in constrictive pericarditis, right ventricular infarction and restrictive cardiomyopathy. Constrictive pericarditis, major cause of right heart failure, hepatic congestion with hepatomegaly and eventual progression to cirrhosis, cardiac cirrhosis, upward arrow JVP with hepatojugular reflux, Kussmaul's sign, lack of downward arrow or an upward arrow in JVP on inspiration, pericardial knock and pericardial calcifications on CXR 40% 30%. Africa, India, China. Sound directly after the second heart sound in, early/mid, diastole. STH like an early S3, echo confirms diagnosis. Show, upward arrow pericardial thickness, abnormal septal motion and biatrial enlargement. RX, diuretics temporary relief, pericardiectomy definitive treatment for refractory cases. Survivors of Hodgkin lymphoma can present as much as 10 to 20 YRS after mediastinal irradiation and / or anthracycline therapy. Cardiac complications of Hodgkin lymphoma include acute or delayed pericardial disease, myocardial ischemia/infarction, restrictive cardiomyopathy, CHF, valvular abnormalities, and conduction defects. Pericarditis. Uremic pericarditis, occur in 1 to 6% PTS of renal failure, involve visceral and parietal membranes of pericardium, does not present with classic ECG findings of pericarditis, as inflammatory cells do not penetrate the myocardium and lack of involvement of epicardium. Dialysis is the most effective treatment for UP and can resolve symptoms and decrease the size of any pericardial effusion. NSAIDs and or colchicine first line for idiopathic or acute viral pericarditis. In UP, used if not responding to dialysis. Avoid anticoagulants. Rightward arrow hemorrhage into pericardial sac. Rightward arrow acute pericarditis can cause diffuse ST segment elevation on EKG, often accompanied with PR depression in limb and left precordial leads, indications for urgent dialysis. Heart block. First degree AV block, due to delayed impulse transmission from atria to ventricles at a number of possible locations including atria, AV node, bundle of his or infra, Hisian conduction system, bundle branches or fascicles. Rightward arrow prolonged PR interval 0.20 SEC, PR interval remains constant. Observation, most first degree AV block with normal QRS are due to conduction delay in AV node. Rightward arrow, no further evaluation needed. Benign but first degree block is associated with higher risk of heart failure, AFib, and overall mortality. Electrophysiologic, first degree AV block with wide QRS, 120 millisecond, conduction delay below AV node. Mostly bundle study branches can have unpredictable progression to second and third degree block and should have electrophysiologic testing to determine the site of conduction delay. Some PTS with first degree AV with marked prolongation of PR interval can develop pacemaker syndrome, uncomfortable sensation of awareness of heartbeat due to atrial contraction against closed mitral valve during ventricular systole. Such symptomatic PTS are potential candidates for pacemaker explantation. Second degree AV block. Mobitz type 1, due to delay of break in cardiac electrical signal pathway from atria to ventricles, can occur in healthy people, athletes, older PTS, those with heart dis, and those who are on drugs that block AV node, E.G. digoxin, beta blockers, calcium channel blockers, constant P interval increasing, PR interval decreasing R interval. There can be a predictable grouping between QRS complexes before dropped QRS complex, E.G. After every 3 QRS complexes, there is a drop. This is called group beating Rx. Observe in asymptomatic PTS as it is benign, ESP in young with good ventricular function, and correctable causes like meds. Can rarely cause significant bradycardia with SX of inadequate cardiac output, e.g. fatigue, lightheadedness, angina, syncope, heart failure, ESP in older PT with acute ischemia or additional cardiac comorbidity. Mobitz type 2, episodic and unpredictable absence of conduction. Third degree / complete AV block, complete failure of impulse conduction between atria and ventricles. SX, dizziness and worsening angina, left untreated rightward arrow ventricular arrhythmia or asystole. Symptomatic PTS should be referred immediately for temporary pacemaker insertion while detailed evaluation for potential causes is performed. Reversible causes, MI, increased vagal tone, E.G. during sleep or due to pain, metabolic disturbance, e.g. hyperkalemia, and AV nodal blocking. Agents, like beta blockers, CCB E.G. verapamil, permanent pacemaker is indicated in absence of reversible causes. Contraindications, beta blockers, digoxin rightward arrow worsen complete block atrial fibrillation, the pulmonary veins, PV, are the most frequent location of ectopic foci that cause AF. Cardiac tissue, myocardial sleeves, extends into PVS and normally functions like a sphincter to reduce reflux of blood into PV during atrial systole. This tissue has different electrical properties than the surrounding atrial myocytes and is prone to ectopic foci and/or aberrant conduction, which can initiate AF. This tissue can be disrupted by catheter-based radiofrequency ablation in those who are unable to achieve adequate rate and rhythm control with standard medical therapy, thereby disconnecting PVS from left atrium. no organized atrial activity and impulses are conducted in a random and unpredictable manner. This leads to absence of any discernible P waves and irregular rhythm with varying R interval, atrial fibrillation with rapid ventricular response, irregular rhythm with narrow complex tachy and no organized P waves. Ventricular rates can be as high as 150/min. Symptoms are due to fast ventricular rate rather than arrhythmia itself. Tachycardia, mediated cardiomyopathy, QID, 4238, tachyarrhythmias with prolonged periods of rapid ventricular rates can lead to this cardiomyopathy. These include AF, atrial flutter, ventricular tachycardia, incessant atrial/junctional tachycardia, and atrioventricular nodal reentrant tachycardia. Initial treatment is aimed at restoration of sinus rhythm or aggressive control of ventricular rate and can lead to significant improvement in left ventricular function. Therapeutic options include AV nodal blocking agents, antiarrhythmic drugs, and catheter ablation of arrhythmia. PTS with new onset AF should be screened for occult hyperthyroidism by TSH and free T4 levels checked. Two issues that need to be addressed in all PTS with new onset AF include choice between rate or rhythm control strategy and risk stratification for prevention of systemic embolization. There is no significant difference in morbidity and mortality between rate and rhythm control strategy. Rate control is preferred over rhythm control in hemodynamically stable PTS. Rate control is achieved by beta blockers, metoprolol, calcium channel blockers, diltiazem, or digoxin to control ventricular rates. Rhythm control, immediate synchronized cardioversion, is needed in hemodynamically unstable PTS with rapid AF. It should be considered in those who do not achieve adequate rate control or recurrent symptomatic episodes, e.g., palpitations, lightheadedness, dyspnea, angina, or heart failure symptoms in setting of underlying left ventricular systolic dysfunction. Attempting cardioversion for an unknown duration or 48 hours without adequate anticoagulation. Inc. Risk of systemic thromboembolism, CHA2DS2, VASC score is used to identify which PT is at highest risk of thromboembolic complication and will benefit from antithrombotic therapy. All PTS with A.fib should be assessed for this. *PT assigned to one of these two categories. All PTS with paroxysmal or persistent AF should have risk stratification with CHADS2 score to assess need of long-term anticoagulation, lone AF, presence of paroxysmal, persistent, or permanent atrial fibrillation with no evidence of cardiopulmonary or structural heart disease. PTS with lone AF are usually 60 and by definition, have CHA2, DS2, VASC score of 0 and need no treatment. Atrial premature beats indicate depolarization of the atria originating in a focus outside SA node. They are seen on ECG as a P wave with abnormal morphology. Often occurring earlier in a cardiac cycle than a normal P wave, benign can occur in healthy people and those with diseased heart, usually asymptomatic but can cause symptoms of skipped beats or palpitations. Can precede a fib, RX, only when symptoms cause distress or when there is SVT. Persistent PACs with symptoms can be treated with low-dose beta blockers, even in asymptomatic PTS. Precipitating factors like tobacco, alcohol, caffeine, and stress should be identified and avoided. In the absence of precipitating factors, transthoracic echo should be performed to look for cardiac/valvular structural/functional abnormality. Supraventricular tachycardia. ECG shows irregular and narrow complex tachycardia, QRS duration 120 milliseconds, at a rate of approximate 160 beats/min, SVT, any tachycardia originating above the His bundle and includes sinus tachycardia, multifocal atrial tachycardia, atrial flutter, atrial fibrillation, AV nodal reentrant tachycardia, often right, AV reentrant tachycardia, AVRT, and junctional tachycardia, Often right, it is because of renin-trans circuit formed by two separate conducting pathways, one fast and one slow. Within AV node, AVRT due to renin-trans circuit involving accessory AV bypass tract, C/F, palpitations, dizziness, lightheadedness, sob, diaphoresis, chest pain, presyncope, or syncope. Paroxysmal supraventricular tachycardia, PSVTs, type of SVT with abrupt onset and offset. They include often right, AVRT, atrial tachycardia, and junctional tachycardia. Sudden onset, regular, narrow complex tachycardia. MOA, entry into AV node. In PTS who are hemodynamically stable, the next step in evaluation is to identify the type of SVT with the use of vagal maneuvers, e.g. carotid sinus massage, Valsalva, eyeball pressure, inserting face in cold water, or 4-adenosine. Adenosine or vagal maneuvers temporarily slow conduction via AV node, and U-World QS can aid in diagnosis by unmasking hidden P waves in PTS with atrial flutter or atrial tachycardia. Tachycardia. They can also cause a transient AV nodal block and terminate AV node dependent arrhythmias, including often right and orthodromic AVRT. 4-beta blockers and CCB can be occasionally given to those who do not respond to vagal maneuver and/or 4-adenosine, in hemodynamically unstable patients with persistent tachyarrhythmia, narrow or wide QRS, hypotension and signs of poor perfusion, cool extremities, signs of shock, ischemic chest discomfort, mental status change, acute pulmonary edema, immediate synchronized direct current cardioversion due to risk of rapid clinical deterioration. It involves delivery of low-energy electric shock synchronized to QRS complex. If possible, provide adequate sedation and analgesia prior to cardioversion. Unsynchronized cardioversion given in ventricular fib, pulseless ventricular tachy, pulseless cardiac arrest. Paroxysmal SVT. Atrial flutter. The most common cause of atrial flutter is a renin-trans circuit around tricuspid annulus, with slowing of the impulse through a region known as the cavatricuspid isthmus. Rapid sawtooth flutter waves are characteristic ECF features of a flutter. Sinus tachycardia. Sinus bradyarrhythmia. Normal heat rate, 60 to 100/min. Sinus brady, HR 60/min, regular rhythm and constant PR interval, can occur normally in adolescents, young adults, well-conditioned athletes, and some elderly ESP during sleep. Pathologic causes, sick sinus syndrome, MI, or ischemia, OSA, hypothyroidism. Hypothyroidism, upward arrow intracranial pressure and meds, SX, usually asymptomatic, but some may develop fatigue, dizziness, light-headedness, hypotension, syncope, angina, and/or CHF. NE is indicated to treat severe hypotension and shock, e.g. septic shock, but not bradyarrhythmia. Approach to wide complex tachycardia. Monomorphic ventricular tachycardia, TE. First thing to do for VTach is stabilize, then look for the underlying cause by serum electrolytes. Loop diuretics cause hypokalemia and hypomagnesemia. These electrolyte abnormalities can cause ventricular tachycardia, and also potentiate the side effects of digoxin causing VTach. UW, 2164, sustained wide complex tachycardia plus fusion beats rightward arrow sustained monomorphic VT, SMVT, presence of AV dissociation is also diagnostic of VT, SMVT occurring early, 6 to 48 hours, during MI is associated with increased risk of in-hospital mortality. Among anti-arrhythmics that can be used for this condition like amiodarone, lidocaine, procainamide, 4-amiodarone is the preferred one. Ventricular premature beat VPB, wide QRS with abnormal morphology, benign and asymptomatic, reassurance plus B blocker. Ventricular tachycardia. Amiodarone and lidocaine is often used in treatment of hemodynamically stable patient with wide, QRS complex tachycardia. Amiodarone is also used in the treatment of atrial fib but not PSVT6 sinus syndrome, impaired SA node automaticity because of fibrosis and/or degeneration of SA node and surrounding myocardium, C/F, fatigue, lightheadedness, palpitations, presyncope or syncope. ECG, bradycardia, sinus pauses/arrest, SA exit block, or alternating bradycardia and atrial tachyarrhythmias, tachyarrhythmia, bradyarrhythmia syndrome. Wolff-Parkinson-White syndrome, accessory pathway conducts depolarization directly from atria to ventricle without traversing AV node. A. Fib occurs in 10 to 30% individual with WPW potentially life-threatening in these PTS. AF in these PTS can bypass usual rate-limiting function of AV node, leading to very rapid ventricular response rates. Persistent AF with rapid ventricular response in PTS with WPW can ultimately deteriorate into ventricular fibrillation. Acute treatment: prompt control of ventricular response and termination of AF as follows. 1. Hemodynamically unstable PTS, immediate electrical cardioversion. 2. Stable PTS, rhythm control with anti-arrhythmic drugs such as 4-ibutylide or procainamide is preferred. Contraindications: AV blocking agents such as adenosine, beta blockers, calcium channel blockers verapamil and digoxin, as they can promote conduction across accessory pathway and degenerate AF into VF. PR interval 0.12 SEC, widened QRS complex. Long QT syndrome. QT interval, depolarization and repolarization of ventricles. Normal duration, variable but 440 milliseconds in males and 460 milliseconds in females. Jervell, Lang, Nielsen syndrome. 1. FH of sudden death, congenital sensorineural hearing loss, QT 600 milliseconds. 2. High risk of syncope, life-threatening ventricular arrhythmia like Torsades and sudden death. 3. RX, refrain from vigorous exercise, avoid meds that prolong QT, maintain normal level of calcium, magnesium, and potassium, and pharmacotherapy. Beta blockers, class 2 antiarrhythmics, except sotalol blunt exertional heart rate and shorten QT interval and is the class of choice. Symptomatic PTS, lightheadedness or palpitations, or those with H/O syncope require beta blockers plus long-term pacemaker placement. Torsades de points. 1. Palpitations, pre-syncope, syncope, may resolve spontaneously or degenerate into ventricular fibrillation and sudden death. 2. RX, immediate defibrillation in hemodynamically unstable PT. 3. Intravenous magnesium sulfate is first-line treatment for conscious and stable PT even if magnesium levels are normal, followed by identification and removal/correction of offending cause. 4. If cause of Torsades de points, TDP, is quinidine use rightward arrow treat with sodium bicarb. Sodium bicarb is also used for cardiac arrest due to metabolic acidosis, hyperkalemia, or gas overdose. Polymorphic ventricular tachycardia in the setting of a prolonged QT interval, cyclic or sinusoidal alteration of QRS axis or morphology, twisting of the points around the isoelectric line. Cardiac arrest. Pulseless electrical activity, P, rightward arrow presence of organized rhythm on cardiac monitor without measurable BP or palpable pulse in cardiac arrest PT. Rightward arrow CPR and vasopressor, 4-epinephrine 1 mg/ 3 to 5 minutes or a single dose vasopressin, to maintain adequate coronary and cerebral perfusion. Rightward arrow CPR should be continued while attempts are made to identify and treat reversible causes of P5HS and TS, VF and sustained VT. Feared complication after MI, electrolyte imbalance, myocarditis, cardiomyopathy, drug side effect. ACLS algorithm for VF and pulseless VT, stresses the importance of early defibrillation. Energy required may be 200 to 360 joules. Greater the time after onset of VF and use of effective bystander CPR, rhythm analysis, and early defibrillator, lower the survival. In witnessed arrest 5 minutes, defib should be performed immediately. If unwitnessed or witnessed arrest 5 minutes before arrival of defibrillator, a cycle of CPR should precede defibrillation. Studies in sudden cardiac arrest has shown better outcomes and improved survival to discharge with compression-only CPR than standard CPR prior to arrival of emergency personnel. No role of synchronized cardioversion and defibrillation in PN/or asystole. Synchronized cardioversion delivers energy synchronized to QRS complex used in symptomatic or sustained monomorphic VT, unresponsive to antiarrhythmics, and hemodynamically unstable atrial fibrillation with rapid ventricular response. Defibrillation delivers energy randomly during cardiac cycle without synchronization to QRS complex. Needed for pulseless ventricular tachycardia and ventricular fibrillation. Factors associated with poor outcome after witnessed off-hospital sudden cardiac arrest. Central venous catheter, commonly used in PTS with difficult vascular access and for long-term administration of medications. Complications occur in 1 to 5% cases and include arterial puncture, pneumothorax, hemothorax, thrombosis, air embolism, sepsis, vascular perforation and myocardial perforation leading to tamponade. CXR should be obtained to confirm proper placement of catheter and absence of complications. To avoid myocardial perforation, catheter tip should be located proximal to either cardiac silhouette or the angle between the trachea and the right mainstem bronchus. Ideally, catheter tip should lie in superior vena cava. Tip placement in smaller vessels can cause perforation. Pulmonary hypertension, defined as mean pulmonary arterial pressure of /equals 25 mmHg at rest, normal 20 mmHg, Rx, endothelin receptor antagonist, e.g. bosentan, PDE5 inhibitor, e.g. sildenafil, and /or prostanoids, e.g. epoprostenol, Rx, loop diuretics and ACEI or ARB, often with beta blockers and in some cases aldosterone antagonists. Rx, oxygen and /or bronchodilators. Rx, long-term anticoagulation due to chronic thromboembolic occlusion. Signs similar to right-sided heart failure. Path, hyperplasia of the intimal smooth muscle layer of the pulmonary arteries leading to increased pulmonary vascular resistance. The lung parenchyma is generally unaffected in PA, which is evidenced by the absence of infiltrates on chest X-ray and normal FEV1 and FEV1/FVC ratio on PFT. Acute dyspnea in hospitalized patient. Aspirin is a common trigger for bronchoconstriction in PTS with asthma, especially those with a concurrent chronic rhinitis and nasal polyps. Cardioselective beta blockers rightward arrow considered safe in PTS with mild, moderate asthma, but all can trigger bronchoconstriction at higher doses and should be used cautiously in asthmatics. Nebivolol is cardioselective. In pleural effusion, there can be DEC. Movement of ipsilateral chest wall as well. Thoracic aorta aneurysm, asymptomatic or chest pain, back pain, flank pain, or abdominal pain depending on location. Ascending aorta aneurysm, arise anywhere from aortic valve to innominate artery, brachiocephalic. Cause, cystic medial degeneration, Cox of aging, or connective tissue disease, e.g. Marfan and Ehlers-Danlos, 40%, descending aorta aneurysm, distal to left subclavian due to atherosclerosis, risk factor, HTN, hypercholesterolemia and smoking, CXR in TAA, widened mediastinal silhouette, upward arrow aortic knob and tracheal deviatin. CXR cannot distinguish TAA from tortuous aorta. Confirm with CT with contrast. Abdominal aortic aneurysm, normal diameter of AA equals 1 to 3 cm, AAA equals 3 cm. Unlike thoracic aortic aneurysm, It does not form false lumen and an intimal flap and is composed of all three layers, usually found incidentally and needs close follow-up because rupture is life-threatening. Imaging modality of choice, abdominal ultrasound, 100% sensitivity and specificity, no need of contrast, inexpensive, facilitates measurement of aneurysm size and show presence of thrombus. Screening, men aged 65 to 75 who have smoked cigarettes have greatest benefit from screening. One-time abdominal USG in such PTS is recommended. Risk factors for developing AAA, older age, 60 YRS, Sig. Smoking, FH of AAA, white race, and atherosclerosis. The risk of AAA rupture increases in PTS with large aneurysm diameter, /equals 5.5 centimeters, aortic expansion rate 0.5 centimeters /6 mo and 1 centimeter /year, female gender, current ongoing smoking and HTN. HTN has weak association with AAA formation and expansion and rupture of AAA present with profound hypotension, abdominal or back pain followed by syncope and examination may show pulsatile mass at or above level of umbilicus. AAA can rupture in retroperitoneal space. Rightward arrow form aortocaval fistula. Rightward arrow venous congestion. Rightward arrow fragile and distended veins in bladder can rupture. Rightward arrow gross hematuria. Screening and surgical repair of /equals 5.5 centimeters aneurysm has shown to decrease mortality. Indications for surgical repair or endovascular repair, size 5.5 centimeters. Rapid rate of expansion 0.5 centimeters /6 mo and 1 centimeter /year and presence of symptoms, abdominal, back or flank pain, limb ischemia, regardless of size. Risk of AAA formation and expansion is lower in diabetics than non-diabetics. Peripheral artery aneurysm, popliteal AA, most common followed by femoral AA, located below inguinal ligament. Compress adjacent structures, nerves and veins, and can cause thrombosis and ischemia. Frequently associated with AAA. Peripheral artery disease, PAD. DX, ankle, brachial index. Rightward arrow abnormal. Rightward arrow arterial duplex USG who are being considered for surgery. A supervised graded exercise is the most useful intervention to improve functional capacity and reduce calcification, include minimum of 12 weeks, with 30 to 45 minutes at least 3 times a WK. Goal, reproduction of claudication symptoms during each session, antiplatelet therapy, low dose aspirin, reduce risk of CAD. Other measures for treating PAD, smoking cessation, aggressive DM control, A1C 7%, and blood pressure control and statins as per recommendation. Silostazol should be considered in those with persistent symptoms despite anti-platelet therapy and supervised exercise programs. Percutaneous or surgical revascularization is reserved for PTS with limb-threatening complications, significant limitation in activities of daily living, or failure to respond to exercise and pharmacologic therapy. PT with PAD equals start aspirin plus lipid-lowering therapy then control other risk factors plus exercise. Silostazol and percutaneous or surgical revascularization should be reserved for those with persistent symptoms despite adequate supervised exercise therapy. Aortoiliac syndrome, Lariche syndrome, arterial occlusion at bifurcation of aorta into common iliac arteries, triad of B/L hip, thigh, and buttock claudication. Impotence and symmetric atrophy of B/L lower extremities due to chronic ischemia. Impotence is almost always present in men and absence should lead to other diagnosis. Pulse is soft or absent B/L from groin distally and in the absence of thorough vascular examination, diagnosis can be missed. Men with predisposition to atherosclerosis such as smoker are at greatest risk for this condition. DVT. C/F, pain, swelling, discoloration of leg. D/D, venous insufficiency, ruptured Baker's cyst, post-thrombotic syndrome, and cellulitis, RX, PT. With clinical evidence of PE, pleuritic chest pain, dyspnea, tachypnea, tachycardia, rightward arrow begin anticoagulant therapy while undergoing diagnostic evaluation, PT. Without PE and only DVT suspected rightward arrow confirm diagnosis before anticoagulants, compression USG is the preferred initial test, proved DVT, begin anticoagulation with heparin followed by warfarin, rivaroxaban, or apixaban. There is no text on this page. Pulmonary embolism, C/F, pleuritic chest pain, does not improve with leaning forward, dyspnea, tachypnea, tachycardia, cough, hemoptysis, and or lower extremity pain/swelling, suggesting DVT, prolonged immobility, CXR, frequently abnormal in PE but has poor sensitivity and specificity. Atelectasis, infiltrates, pleural effusions, Westermarck's sign, peripheral hyperlucency due to oligemia, Hampton's hump, peripheral wedge of lung opacity due to pulmonary infarction, and Fleischner's sign, enlarged pulmonary artery. Heparin is given if there is high probability of having PE. Guidelines for lipid-lowering therapy. There is no recommended LDL level, but it should be checked after starting statins to assess response and PT adherence. Hypertriglyceridemia. Cholesterol crystal embolism can be immediate or delayed, /30 days after inciting event. Advanced age, smoking, and obesity are also risk factors. Skin manifestations are most common. Blue toe syndrome, cyanotic toes with intact pulses. Livedo reticularis, blanches with pressure application, Hollenhost spots, bright, yellow, refractal plagues in retinal artery. Some may have persistent renal failure 2 weeks in contrast to dye-induced renal injury which usually resolves in 1 WK, Rx, supportive and reinforces the use of statin therapy. Acute limb ischemia, occurs from arterial occlusion caused by cardiac emboli, thrombosis, e.g. vascular stents, hypercoagulable state, or trauma. Major cardiac sources of arterial emboli, 1. LV thrombus. 2. Thrombus, usually left atrial, formation due to a fib. 3. Aortic atherosclerosis, PTS with large anterior ST, elevation MI, STEMI, are at highest risk of LV thrombus and anteroapical aneurysm formation. Acute arterial occlusion of extremity leads to 6 PS, pain, pallor, poikilothermia, cool extremity, paresthesia, pulselessness, and paralysis. Immediately start on anticoagulation and vascular surgery evaluation while further diagnostic procedures are performed. 4. Heparin prevent further thrombus propagation and thrombosis is distal arterial and venous circulation. Transthoracic echocardiogram with echo contrast must be performed to screen LV thrombus and evaluate LV function. Carotid endarterectomy, lesion 50% are typically monitored with annual duplex USG. They are medically managed at this stage with pharmacotherapy, e.g. antiplatelet agents and statins, and risk factor optimization, e.g. tobacco cessation, DM, and HTN control. Asymptomatic carotid artery stenosis can progress to TIA or embolic stroke. Symptomatic means occurrence within past 6 months of sudden onset focal neurological symptoms corresponding to a carotid artery lesion. New guidelines 1. 70% or asymptomatic equals medical TTT2. 70% plus SX or 80% equals endarterectomy. Carotid endarterectomy, CEA, is recommended for men and women with symptomatic carotid stenosis of 70%, 99% and is also beneficial for men with asymptomatic carotid stenosis of 60%, 99%. Syncope. Syncope is defined as a transient loss of consciousness accompanied by loss of postural or motor tone with a spontaneous return to baseline neurologic function. It is usually benign and self-limiting. Clonic jerks can occur during any syncopal episode that is prolonged and associated with cerebral hypoxia, regardless of etiology. Transient ischemic attacks, TIAs, are an infrequent cause of syncope, as the TIA must affect the posterior circulation and brainstem to cause syncope. Vasovagal syncope. Most common due to excessive vagal tone. Also known as neurocardiogenic syncope. Particularly common in young women, being and self-limited in most cases. Diagnosis is usually clinical and needs no further testing if history and physical exam points strongly toward the diagnosis and resting ECG is normal. During upright tilt table test, PT lies down, strapped on an examination table. Continuous ECG and BP monitoring are used throughout the test. Exam table moves passively from a supine to a head, up position between 60* to 90*. PT is held in this position for 20 to 45 minutes. If there are signs of unconsciousness, E.G. syncope, inability to maintain posture due to fall in BP or pulse, diagnosis is confirmed and test is stopped. Test has limited sensitivity and specificity. Carotid sinus hypersensitivity syndrome, syncopal episodes triggered by neck movement or pressure on carotid sinus by tight neck collars. This is a cause of unexplained falls in older adults, 40 YRS. Carotid sinus massage is considered diagnostic if PT develops asystole 3 seconds, a fall in systolic BP 50 mmHg, and or reproduction of symptoms, e.g., syncope, situational syncope, specific situation like micturition or coughing fit can lead to syncope. Commonly in middle age or older male. MOA, autonomic dysregulation which can partially be explained by straining and rapid bladder emptying. Cardioinhibitory and or vasodepressor mechanisms may be involved. Orthostatic hypotension, drop in systolic BP 20 mmHg and diastolic 10 mmHg on standing from sitting position within 2 to 5 minutes of standing from supine position. Reasons for the increased incidence of orthostatic hypotension in the elderly. Due to decreased baroreceptor sensitivity leading to decreased constriction of resistance and capacitance vessels, DEC. Intravascular volume / hypovolemia, meds, DEC. Catecholamines in nerve endings. Decreased myocardial sensitivity to sympathetic stimulation. Autonomic neuropathy, E.G. diabetes and Parkinson disease, elderly and prolonged recumbence increases risk. People often note pre-syncopal lightheadedness sensation. Upward arrow bun and bun/creatinine ratio is a sensitive but not specific indicator of hypovolemia. It is because of downward arrow GFR and upward arrow urea reabsorption. Bun/creatinine ratio upward arrow with increasing severity of hypovolemia, urine Na+, ESP if PT is on diuretic as well, blood K+, lactic acidosis are not sensitive indicators of hypovolemia. Sensitive for hypovolemia, 1. Bun 2. Ernie Na, unless taking diuretic. Aortic stenosis, syncope, fatigue, downward arrow pulse pressure, pulsus parvus et tardus, crescendo, decrescendo endo murmur at right upper sternal border, soft and single S2 due to delayed A2 and reaching P2, hence a single, soft murmur is heard. Early peaking systolic murmur mild to moderate stenosis, late peaking systolic murmur severe as pulsus parvus et tardus, arterial pulse with decreased amplitude and delayed peak, common in severe aortic stenosis. Aortic regurgitation. Murmur is high-pitched, blowing, and best heard along left lower sternal border, may be soft and heard in some patients only by applying firm pressure with the diaphragm while PT is sitting up, leaning forward and holding breath in full expiration. Left ventricular enlargement brings apex close to chest wall and causes uncomfortable sensation of heartbeat and pounding sensation ESP. In left lateral decubitus position, water hammer pulse is also called Corrigan pulse. Developed countries most common cause, bicuspid aortic valve or aortic root dilation. Developing countries, rheumatic fever pulsus bisferens, or biphasic pulse. 2 strong systolic peaks or aortic pulse from left ventricular ejection. Separated by a mid-systolic dip. Can be palpated in PTS with significant aortic regurg. With or without stenosis, HOCM, and occasionally large PDA. Infective endocarditis, abnormal urine, proteinuria and/or hematuria, and swollen interphalangeal joints, arthritis. Extensive evaluation is needed for definitive diagnosis. Empiric treatment with vancomycin after obtaining blood cultures, cover staph, strep and enterococci. Most viridans group streptococci are highly susceptible to penicillin with minimum inhibitory CONC /equals 0.12 g/ml. Penicillin susceptible strains should be treated with 4-aqueous penicillin G, every 4 to 6 hours or 24 hours continuous infusion, or 4-ceftriaxone, once daily, for 4 weeks. Ceftriaxone is easier to administer at home due to once-daily dosing. Oral antibiotics are generally not recommended as initial therapy in patients with IE. Can be considered in some patients, but then combination therapy is given rather than monotherapy. Complications of infective endocarditis. Rheumatic fever. All PTS with initial diagnosis of rheumatic fever should be treated with antibiotic therapy to eradicate gas regardless of presence or absence of pharyngitis at the time of diagnosis. PTS with H/ORF are at increased risk of recurrence and progression of RHD with repeat episodes of gas pharyngitis. Mitral stenosis is almost always due to RF. PTS with symptomatic MS need preload reduction with diuretics or nitrates and not after load reduction with ACEI, etc. Marfan syndrome aortic dissection. 50% cases in PPL 40 years are due to Marfan syndrome, but HTN is most common risk factor seen in 75% patients. PTS with aortic dissection and/or progressive aortic root dilation can develop aortic regurgitation murmur heard best at left lower sternal border with PT sitting up and leaning forward and holding breath after full expiration. Aortic dissection murmur is heard better on right sternal border compared to left for primary valvular disease. Pain can also radiate to neck. Stanford type A, involve ascending aorta. Stanford type B, involve only descending aorta. Acute type A aortic dissection can occasionally cause occlusion of right coronary artery by dissection flap, leading to inferior MI. Aortic dissection can extend into renal arteries leading to acute renal failure, RX. Type A, acute lowering of BP with labetalol plus surgery. Type B, usually managed with labetalol alone. Management, 1. Even if transthoracic echo has been performed, transesophageal echo is performed in emergency room to confirm the diagnosis, as it is more sensitive and specific and help visualize ascending, transverse and descending aorta. CT and MRI are alternatives if emergency T is not available too. Beta blockers are used as they decrease heart rate and BP, minimizing stress on aortic wall. Vasodilators should not be used as they can cause reflex tachy, further increasing stress on walls. Only use if further BP is to be lowered after beta blockers already given. Anticoagulants and fibrinolytics should never be used. 3. Emergency pericardiocentesis is needed in those who are not hemodynamically stable. Holt, Oram syndrome, Hart-Hand syndrome, both upper limb defects, E.G. Deformities of radius and carpal bone, and atrial septal defect. Alcohol withdrawal. Hypertension, malignant HTN common in long-standing and uncontrolled HTN. In malignant HTN, there can also be malignant nephrosclerosis, ARF. Hematuria and proteinuria. However, these are not always present and not diagnostic criteria. Hypertensive emergency, severe HTN plus end organ failure, BP should be lowered 10 to 20% in first hour and 5 to 15% in next 23 hours. Excessive drop in BP, rightward arrow, cerebral ischemia, altered mental status and/or generalized seizures. Hypertensive encephalopathy, INC BP with signs and symptoms of cerebral edema, C/F, headache, nausea, vomiting, non-localizing neurological symptoms. Symptoms: restlessness, confusion, agitation, seizures, and coma. PT can also develop intracerebral or subarachnoid hemorrhage. Work up of hypertension. Most people have essential HTN, but initial evaluation should assess possible secondary causes. Basic workup includes 1. Investigating duration of HTN, extent of target organ damage and cardiovascular risk factors. 2. Basic labs include urine analysis, for occult hematuria and protein/creatinine ratio, chemistry panel lipid profile, risk stratification for coronary artery dis, baseline ECG, to evaluate for coronary artery dis or left ventricular hypertrophy. Further evaluation is needed for those with signs/symptoms of possible 2 degrees HTN treatment of hypertension. Isolated systolic hypertension initial treatment, monotherapy with low-dose thiazide diuretic, ACEI, or a long-acting calcium channel blocker. Systolic HTN can also occur in hyperthyroidism because of hyperdynamic state. Signs of hyperdynamic state, ventricular heave or dynamic precordium. Upon examination, most common features of mitral regurgitation are exertional dyspnea and fatigue. 2 * to decreased cardiac output and inc. Left atrial pressure. Dry cough can occur in case of LV dysfunction in more severe cases, causing pulmonary congestion and edema. Most effective method to control HTN is lifestyle modification. 1. Reducing weight is most imp in obese PTS. 2. Diet is most imp in non-obese PTS. This has more importance than low-sodium diet to lower BP. Anti-hypertensives in pregnancy, calcium channel blockers and peripheral edema. CCB cause preferential dilation of pre-capillary vessels, arteriolar dilation, rightward arrow increase hydrostatic pressure in capillaries. Rightward arrow edema, also cause headache, flushing and dizziness. ACEI or ARBs cause dilation of post-capillary venules, and when used in combination with CCBs, there is lower risk of CCB-associated peripheral edema, by normalizing capillary pressure. Cyanide toxicity, nitroprusside, quick onset and offset and used in hypertensive emergency, if given for longer time or in higher doses, can cause this ESP in renal insufficiency, C/F, altered mental status, lactic acidosis, seizures, and coma. Beta blocker toxicity, bradycardia, hypotension, AV block, cardiogenic shock, wheezes, Cox of bronchospasm, hypoglycemia, neurologic like delirium, seizures, etc. AV block, hypotension, and bradycardia can occur with CCB, anticholinergics and digoxin. 2. Management. 1. Secure airway. 2. Give isotonic fluid boluses, and 4. Atropine for hypotension and bradycardia. 3. 4. Glucagon if refractory or profound hypotension. Rightward arrow, upward arrow, camp and effective in BB and CCB toxicity. 4. Other therapies that can be used simultaneously or in succession: 4. Calcium, vasopressin, epinephrine or NE, high-dose insulin and glucose, and 4. Lipid emulsion therapy. Secondary causes of HTN. All PTS with resistant HTN, severe or malignant HTN, sudden BP rise in a PT with previously controlled BP, age of onset 30 years without family H/O HTN should be screened for 2 * causes of HTN, resistant HTN, persistent HTN despite using /=3 antihypertensive agents of different classes, one being a diuretic. Significant HTN with primary hyperparathyroidism suggest possible evaluation of men 2 with pheochromocytoma. Renovascular HTN/renal artery stenosis, most common and most correctable cause of 2 degrees HTN, not responsive to antihypertensives, should be suspected and evaluated in following cases plus those in table above. 1. Upward arrow serum creatinine 30% from baseline after starting ACEI or ARB. 2. Severe HTN in PTS with diffuse atherosclerosis. 3. HTN in a PT with asymmetric kidney size or a small atrophic U/L kidney, ESP. Common in PTS with H/O atherosclerotic dis. An abdominal bruit, systolic, diastolic bruit is heard in this case. Only systolic bruit is heard in AAA, 99% specific and 40% sensitive rightward arrow difference in BP in arms, in left than right, subclavian atherosclerosis, in right arm than left, coarctation proximal to left subclavian artery origin, in case of aortic dissection but chest pain radiating to back is also present. Autosomal dominant polycystic kidney disease, HTN usually precede decline in renal function. Fibromuscular dysplasia, most common cause of 2*HTN in children. Fibromuscular dysplasia. Usually women 15 to 50, it is non-inflammatory and non-atherosclerotic condition. Abnormal cell growth in arterial wall. Rightward arrow vessel stenosis, aneurysm or dissection, physical examination, hum or brute in costovertebral angle due to well-developed collaterals. Right renal is more affected than left. Rightward arrow renin and angiotensin. Upward arrow, 2 degrees hyperaldosteronism, but ratio remains 20. Carotid brute can also be heard, angiography, string of beads pattern to renal artery. Remember women stenosis of renal artery is common in elderly, 50 yo and ESP. In males, more common on left side. Brute may be heard but is unrelated to stenosis. In primary hyperaldosteronism. Rightward arrow upward arrow aldosterone and downward arrow renin. Rightward arrow aldosterone renin 20. Coarctation of aorta. Systolic ejection murmur at left interscapular area, PT may be at increased risk of shock, delayed capillary refill. 3 SEC, metabolic acidosis, downward arrow renal perfusion, downward arrow urine output. With increased voltage of QRS complexes and ST and T wave changes in left precordial leads V5 and V6. All PTS ESP. Young with systemic HTN should be evaluated for coarctation of aorta with simultaneous palpation of brachial and femoral pulses to assess for brachial, femoral delay, check supine B/L arm, brachial, and prone right and left leg, popliteal, BP to assess for differential pressures. Heparin-induced thrombocytopenia. There are 2 types, type 1 HIT, non-immune direct effect of heparin on platelet activation and usually presents within first 2 days of heparin exposure. The platelet count then normalizes with continued heparin therapy and there are no clinical consequences. Type 2 HIT, more serious, immune-mediated due to antibodies to platelet factor 4, PF4, complexed with heparin. Rightward arrow platelet aggregation, thrombocytopenia, and thrombosis, both arterial and venous. Platelet count usually drops =equals 50% from baseline, with a nadir of 30,000 to 60,000 ul. Presents 5 to 10 days after initiation of heparin therapy and may lead to life-threatening consequences, e.g. limb ischemia, stroke. Cytochrome P450 inducers and inhibitors. Acetaminophen, if taken at significantly high doses, 2g/day, for 1 week can significantly enhance effect of warfarin. Digitalis toxicity. Atrial tachycardia with AV block is arrhythmia specific for digitalis toxicity. Digitalis is responsible for increased ectopy in atria and ventricles. Rightward arrow atrial tachy, 350 bpm, P, waves present but different from normal P, waves. Closer the ectopic focus to SA node, more is the resemblance of ectopic P, wave to normal P, wave. Digitalis causes Inc. In vagal tone. Rightward arrow AV block, multifocal atrial tachy is rarely associated with digitalis toxicity. It is more commonly a consequence of pulmonary dis. Amiodarone or verapamil, quinidine, and propafenone increases the serum levels of digoxin and can lead to toxicity. Acute toxicity has predominant GI symptoms and chronic has predominant CNS symptoms. It is recommended that the digoxin dose be decreased by 25%, 50% when initiating amiodarone therapy, with close monitoring of digoxin levels once weekly for the next several weeks. Amiodarone toxicity. Use of amiodarone, serious ventricular arrhythmia in PTS with coronary artery disease and ischemic cardiomyopathy, rhythm control in atrial fibrillation and underlying left ventricular dysfunction, 50% PTS on long-term amiodarone will develop S/E. Pulmonary toxicity, serious adverse effect of long-term use. Can also present with ARDS. Correlates with total cumulative dose rather than serum drug level and usually occurs months to several years after initiation of drug therapy. Baseline CXR and pulmonary function testing prior to therapy initiation, and long-term by development of signs and symptoms, cough, fever, dyspnea, suggestive of pulm. Toxicity, abnormal LFTs, discontinue if 2-fold are seen, corneal deposits, as drug is secreted in lacrimal glands. Vision usually unaffected. Does not require drug discontinuation. Routine monitoring, TFT, before starting and 3 to 4 months interval, and LFTs, suspicious pulm symptoms, CXR and PFTs, visual SYMT-PMS, thorough ophthalmologic examination. Serotonin syndrome. Adverse effects of phosphodiesterase 5 inhibitors. If alpha blockers are to be used along with PDE5I, then they should be used with caution. Minimum effective dose of both drugs should be given, with careful dose titration. Should be taken 4 hours apart. All antihypertensives should be used with caution with PDE5I. Diabetic retinopathy is not a CI for PDE5I. PDE5I cause temporary bluish discoloration due to cross-reactivity with PDE6 inhibitors involved in color vision in retina. Non-arteritic optic neuropathy, NAN, noted with PDE5I use but relationship is unclear. PDE5I have been found to decrease symptoms of diabetic peripheral neuropathy and PAD. Renin, angiotensin, aldosterone system. COR pulmonale. SX, occasionally ascites or pleural effusion, right ventricular third heart sound, loud P2, anorexia and abdominal pain due to hepatic congestion, right heart catheterization. Definitive diagnosis can be made using right heart catheterization showing elevated pulmonary artery systolic pressure, 25 mmHg. Shock. Hypovolemic shock. Consider hypovolemia in any PT with MVA from hemorrhage unless otherwise proved. Severe hemorrhage rightward arrow downward arrow venous return rightward arrow downward arrow end diastolic volume rightward arrow downward arrow rightward arrow upward arrow sympathetic activity rightward arrow upward arrow venous capacitance vessels rightward arrow improve venous return rightward arrow flat neck veins. If positive pressure mechanical ventilation is given without correction of intravascular volume loss rightward arrow upward arrow intrathoracic pressure rightward arrow upward arrow right atrial pressure rightward arrow downward arrow systemic venous return rightward arrow acute circulatory failure rightward arrow death. Additionally, sedative meds given prior to intubation also relax venous capacitance vessels and may themselves cause circulatory failure by acutely decreasing venous return in hypovolemic PT, may not respond well to fluid resuscitation. Septic shock, hyperdynamic phase, DEC. In SVR, DEC. BP, Inc. HR & Co., warm shock, hypodynamic phase, Inc. SVR, DEC. In Co. rightward arrow grave deterioration, cold shock. Exertional heat stroke. Sweating is the main mechanism of heat dissipation. If humidity 75% or excessive ambient heat rightward arrow DEC. Sweating, antihistamine/anticholinergics rightward arrow impair heat dissipation rightward arrow heat stroke, often anhidrosis is described as classic finding. PTS can have excessive sweating, dehydration common rightward arrow tachycardia, hypotension, hemoconcentration, Inc. HB, leukocyte and platelet count, and Inc. Bun. Leukocytosis rightward arrow from severe stress non-exertional heat stroke, similar C/F and potential complications as above, occurs in absence of strenuous activity. More frequently affect elderly PT with significant underlying comorbidities that limit their ability to escape or cope with excessive heat, RX, evaporative cooling, e.g. spraying lukewarm water while fans blot air on PT, is more imp than ice immersion, which is associated with ink mortality in this case. Cardiac myxoma. Myxomas are the most common. Benign primary cardiac tumor. Because of IL-6, transesophageal echo is most sensitive, though transthoracic is also adequate. Hyperthyroidism. Hyperthyroidism. Rightward arrow, upward arrow. Beta adrenergic receptors. Rightward arrow, upward arrow. Sympathetic activity, Rx. Beta blockers, like propranolol, atenolol, should be started in PTS with hyperthyroidism as soon as it is diagnosed and continued till euthyroid with thinomides, radioiodine, and/or surgery. Scleroderma. Renal crisis, malignant HTN, e.g. headache, blurry vision, nausea, and acute renal injury without previous kidney injury. Upward arrow. Creatine or BUN, in the setting of systemic sclerosis, scleroderma, rightward arrow. Scleroderma. Renal crisis, affects 20% PTS with diffuse cutaneous systemic sclerosis, SSC, within first 5 years of diagnosis, MOA. 1. Upward arrow. Vascular permeability. 2. Activation of coagulation cascade. 3. Upward arrow. Renin secretion. Urine analysis can be normal or show mild proteinuria. Peripheral blood smear can show microangiopathic hemolytic anemia, similar to HUS/TTP, or DIC with fragmented red blood cells, e.g. schistocytes, and thrombocytopenia. Burr cells, echinocytes, serrated edges in liver disease and ESRD. Howell, Jolly bodies, H/O splenectomy or functional asplenia. Spur cells, irregularly spaced projections in liver disease. Target cells, in hemoglobinopathies, e.g. thalassemia, or CLD, ESP. Obstructive liver disease. Contents. Breath holding spells. 2. Turner syndrome. 2. Congenital heart defects. 2. Normal fetal circulation. 2. Transposition of great vessels. 3. Tricuspid atresia. 3. Complete atrioventricular canal defect. 4. VSD. 4. Epstein anomaly. 5. Tetralogy of Fallot. 5. Total anomalous pulmonary venous return. 5. Truncus arteriosus. 5. Patent ductus arteriosus. 6. Pediatric viral myocarditis. 6. Kawasaki disease. 7. Digi-EORGE syndrome. 8. Stridor. 8. Croup. 8. Laryngomalacia. 9. Vascular ring. 9. Cardiology, pediatrics. Breath holding spells. BHS is benign and parents should be reassured, common in 6mo to 2YRS and usually stop by 5YRS, and child usually develops normally. May represent variant of vasovagal syncope. Some may develop vasovagal syncope later in life, iron deaf. Anemia can also cause this, and supplements are given if anemia found. In pallid form, there may be confusion and sleepiness for a few minutes. If recurrent and prolonged, or FH of cardiac dis. Syncope, or sudden death. Rightward arrow. ECG. Echo if murmur, poor growth, or diaphoresis/dyspnea with feeds of activity. Turner syndrome, coarctation of aorta is common. Rightward arrow. Continuous murmur is heard all over chest due to development of collaterals between hypertensive and hypoperfused vessels. Rib notching is due to dilation of collateral chest wall vessels. Congenital heart defects. Normal fetal circulation, blood is shunted away from lungs by PDA, and systemic circulation mainly relies on right ventricle. Right ventricle is larger than left in normal newborn. ECG, right axis deviation are waves in precordial leads, V1, V3, on ECG. If hypoxia fails to improve with inhaled oxygenation. Rightward arrow. Congenital heart disease, oxygen saturation of 70 to 90% and central cyanosis. Rightward arrow. Cyanotic heart disease. There is no text on this page. Normally deconstricts and becomes non-functional around day 3 of life. Closure in PDA-dependent CHD can lead to severe hypoxia, shock, and lactic acidosis. Keep it open with PGE1 until surgery can be performed. Excessive inspired oxygen and indomethacin should be avoided as they constrict the transposition of great vessels. Most common neonatal cyanotic heart dis. Mostly present within 24 hours of birth. Single S2 because pulmonary component is missing as it lies behind aorta. PDA or VSD, both cause murmur, or patent foramen ovale. No murmur is needed for mixing of oxygenated or deoxygenated blood after birth. Inadequate mixing rightward arrow rapid severe cyanosis and pulmonary edema. If shunt is not developed, emergency atrial septostomy. If TGV is suspected, prostaglandins should be started to maintain mixing and echo should be obtained. Tricuspid atresia, cyanosis, lack of communication BTW right heart chambers lead to hypoplastic right ventricle and diminished right ventricle forces on ECG, lack of right ventricle filling and pulmonary outflow tract rightward arrow underdevelopment of pulmonary valve and/or artery rightward arrow deck. Pulmonary markings on CXR, ASD and VSD are needed for survival. There is no text on this page. ECG, left axis deviation and small or absent R waves in precordial leads. Tall peaked P waves because of ASD causing INC. Blood flow to right atrium and subsequent enlargement, cause, unknown but can occur with any congenital heart defect and in FH of CHD, RX, surgical repair rightward arrow improve 10-year survival to 80%. Lack of repair rightward arrow death in first year of life. There is no text on this page. Complete atrioventricular canal defect, most common congenital heart defect in Down syndrome, underdeveloped AV valves, ASD, VSD, diaphoresis/dyspnea with feeds usually present at 6 weeks when pulmonary vascular resistance falls. Auscultation findings, 1. Loud S2 due pulmonary HTN2. Systolic ejection murmur from increased flow across pulmonary valve from left to right shunt across ASD3. Hollow systolic murmur of VSD may be soft or absent if defect is large, CXR, Inc. Pulmonary marking and cardiomegaly from excessive pulm blood flow and biventricular volume overload. VSD, range from small, asymptomatic to large causing L rightward arrow R shunt, failure to thrive, easy fatigability, and heart failure. Pansystolic murmur at left lower sternal border and diastolic rumble at apex due to increased flow of blood across mitral valve rightward arrow echo to evaluate size and location of defect, RX, depends on size of defect and severity of symptoms generally combination of meds, e.g. diuretics, and transcatheter or surgical closure, ideally well before development of Eisenmenger syndrome. Small VSDs close in 75% children spontaneously by age 2 years with no long-term sequel. There is no text on this page. Epstein anomaly, malformed tricuspid valve into right ventricle rightward arrow droopy tricuspid valve rightward arrow severe tricuspid regurgitation rightward arrow right atrial enlargement rightward arrow tall P waves and right axis deviation, auscultation, triple or quadruple gallop, widely split S1 and S2 plus allowed S3 and/or S4, and hollow systolic or early systolic murmur at left lower sternal border, CXR, extreme cardiomegaly from heart failure. Tetralogy of Fallot. PT with mild obstruction can develop hypercyanotic or TET spell because of dramatic infundibular spasm during exertion or agitation. This situation is dangerous, so they should be placed in knee, chest position immediately to INC. SVR, INC. Pulm blood flow and improve symptoms and cyanosis. Oxygen should be given to stimulate pulm. Vasodilation and systemic vasoconstriction, morphine to relax PT. And 4 fluids to improve right ventricular filling and pulmonary flow. DEC. Vascular markings on CX are due to pulm outflow tract obstruction. Boot-shaped heart develops later but they have right axis deviation as in normal newborn, Elective surgical repair is performed before 6 mo of age to decrease morbidity and mortality from outgrowing the RVOT. Total anomalous pulmonary venous return. All pulmonary veins drain into SVC rightward arrow right atrium and ventricular enlargement rightward arrow right axis deviation as normal rightward arrow Inc. Markings on CX are due to Inc. Pulm blood flow truncus arteriosus, strongly associated with DiGeorge syndrome, normal ECG, CXR, cardiomegaly and Inc. Pulmonary vascular markings from heart failure and pulmover circulation. There is no text on this page. Patent ductus arteriosus, associated with congenital rubella syndrome and Char syndrome, affects face, heart, and limbs. Continuous murmur Cox of continuous flow of blood from aorta to pulm. Artery because pressure in aorta is always more than pressure in pulmonary artery. C/F depend on size and length of PDA. Small PDA usually asymptomatic. May show mildly accentuated peripheral pulses. Pediatric viral myocarditis QID 4854. Myocarditis is potentially lethal. Cause, viral, autoimmune, and toxins. Pathogenesis, direct viral injury and autoimmune inflammation that leads to myocyte necrosis rightward arrow impairment of systolic and diastolic function, more severe in newborns, can cause death because immature myocardium is less adaptable to acute insult. Symptoms overlap with other pediatric illnesses misdiagnosed as asthma or pneumonia. There is no text on this page. Hollow systolic murmur, can be heard 2 to dilated cardiomyopathy leading to MR, CXR, healthy infant 1 year, transverse cardiothoracic ratio / equals 60%. Healthy 1 year, / equals 50%, ECG, may show nonspecific T-wave changes. Echo is best. Viral studies should be sent to identify offending pathogen, Rx, supportive such as diuretics and inotropes. Affected children should be monitored in ICU due to risk of shock and fatal arrhythmias. Acute rheumatic fever, occurs after 2 to 4 weeks of group A streptococcal infection. Uncommon in children 3 years. Cox of fewer epithelial cell attachment sites in throat. Kawasaki disease. Diagnosis is clinical. Irritability is also a common feature, typically in children 5 years but can occur in late childhood as well. Treatment should be started within 10 days of fever onset to prevent cardiac complications. Baseline echo in all suspected PTS and repeat 6-8 weeks later to monitor for changes. D/D. In strep throat, there is pharyngeal exudate as well. Rash is sandpaper-like and spares palms and solace. DiGeorge syndrome. Truncus arteriosus is most commonly associated with DiGeorge syndrome. Other anomalies include TOF, interrupted aortic arch and septal defects. If DGS is suspected, immediate serum calcium and echo should be ordered. Hypocalcemia rightward arrow tetany, seizures, and arrhythmia which can exacerbate underlying heart disease. Stridor. Croup. Often caused by parainfluenza virus, most common cause of inspiratory stridor, response to treatment with racemic epinephrine or corticosteroids. Laryngomalacia, caused by increased laxity of supraglottic structures that result in collapse during inspiratory phase. Vascular ring, result from abnormal development of aortic arch causing tracheal, bronchial, or esophageal compression. Rightward arrow stridor, wheezing, cough, dysphagia, or difficulty feeding. They are either completely surrounding trachea and / or esophagus, or incomplete. Common examples: right-sided aortic arch, double aortic arch, pulmonary sling, or anomalous left carotid or innominate artery. Do not improve with nebulized racemic epinephrine, corticosteroids, or bronchodilators. DX, require high index of suspicion, confirmed with barium contrast esophagogram, bronchoscopy, CT or Mr. angiography. RX, surgery is the only definitive treatment in severe disease. There is no text on this page. Contents: venous valve insufficiency. 2. Rapid deceleration blunt chest trauma. 2. Aortic injury. 2. Pulmonary contusion. 2. Esophageal rupture. 2. Myocardial rupture. 3. Myocardial contusion. 3. Diaphragmatic rupture. 3. Bronchial rupture. 3. Compartment syndrome. 3. Avenue fistula. 4. Acute post-op mediastinitis. 4. Pericardiotomy syndrome. 4. Post-pericardiotomy syndrome. 4. Retroperitoneal hematoma. 5. Cardiology, surgery. Venous valve insufficiency, most common cause of lower extremity edema, approximate 2% population affected, edema aggravated after exertion / throughout the day and relieved with walking, rest / leg raising. Associated with cramping and heaviness, failure of venous valves causes blood to pool in dependent parts like legs. Rightward arrow Inc. In capillary hydrostatic pressure. Rightward arrow Inc. Filtration of fluid out of capillary into interstitial space. Rightward arrow Dec. In intravascular volume. Rightward arrow stimulates kidney to retain salt and water. Rightward arrow progression of edema, failure of venous valves. Rightward arrow Inc. Pressure in post-capillary venule. Rightward arrow capillaries leak. Rightward arrow loss of fluid, plasma proteins and RBCs into tissue. Rightward arrow RBC extravasation leads to hemosiderin deposition in tissue and classic coloration of stasis. Dermatitis mostly involve medial leg below knee and above medial malleolus. Inflammation of capillaries and venules plus fibrin deposition and platelet aggregation cause microvascular disease and ultimately ulceration. Xerosis most common early finding, lipodermatosclerosis and ulceration. Late disease, initial treatment, leg elevation, exercise and compression stockings. Rightward arrow no response, venous duplex ultrasound to identify reflux or insufficiency. Rightward arrow persistent and documented reflux, endovenous ablation. Arterial occlusion causes pain, pallor, paresthesia, pulselessness, and coolness to touch. Rapid deceleration blunt chest trauma. Aortic injury, patient suffering from rapid deceleration blunt chest trauma or fall from a height 10 feet is at high risk of aortic injury. Usually aortic transection, circulatory collapse, and death are immediate sequelae. Some may have incomplete or contained injury, SX, nothing specific, but anxiety, HTN and tachycardia are common. Hypotension, external evidence of trauma and altered mental status usually present. Management, once stabilized with airway, breathing and circulation secured, perform upright CXR. CXR will show widened mediastinum, large lead-sided hemothorax, deviation of mediastinum to right and disruption of normal aortic contour, depression of left mainstem bronchus. Confirm DX with CT scan and angiography, RX, antihypertensive where appropriate and surgical repair. Pulmonary contusion, most common finding after blunt chest trauma. CXR, opacities caused by hemorrhage in involved lung segments. Esophageal rupture, rare, cause pneumomediastinum and pleural effusion but not circulatory collapse. Myocardial rupture, cause sudden death but rarely cardiac tamponade in case of contained injury. Myocardial contusion, classically causes tachycardia, new bundle branch block or arrhythmia. Sternal injury is usually associated diaphragmatic rupture, abdominal pain, pain referred to shoulder, sob, and vomiting, radiography, abdominal viscera above diaphragm and loss of diaphragmatic contour. Bronchial rupture, rare, pneumothorax that does not resolve with chest tube placement, pneumomediastinum and subcutaneous emphysema. Compartment syndrome, reperfusion of limb following arterio-occlusive ischemia for longer than 4 to 6 hours can lead to intracellular and interstitial edema and can also lead to intracellular swelling. Compartment syndrome may occur when edema causes the pressure within a muscular facial compartment to rise above 30 mmHg or delta pressure, diastolic pressure, compartment pressure, or delta pressure, diastolic pressure, compartment pressure, 30 mmHg leading to further muscle and nerve ischemia. Compartment syndrome is more common after traumatic injuries of extremities, ESP. Long bone fractures, but can occur post-ischemia, RX. If compartment pressures are improving, PT can be closely observed. If no rapid improvement, then fasciotomy is performed to avoid long-term complications. Bone infarction can also produce erythema and warmth, but not swelling. Recurrent embolism can produce similar features as compartment syndrome, but there are absent pulses, pallor and lack of swelling. DVT can cause calf tenderness and exacerbation pain on passive stretching, but it is often asymptomatic and generally associated with only vague aching pain. AV fistula rightward arrow deck. In systemic vascular resistance, Inc. Cardiac preload, and Inc. Cardiac output and stroke volume to maintain oxygenation of peripheral tissues. Rightward arrow wide pulse pressure, strong peripheral arterial pulsation, E.G. Brisk carotid upstroke, systolic flow murmur, tachycardia, flushed extremities. Rightward arrow left ventricular hypertrophy and point of maximal impulse shift to left. Rightward arrow high output cardiac failure. Other causes of high output cardiac failure: thyrotoxicosis, Paget disease, anemia, and thiamine def. DX, Doppler USG, RX, surgical for large AVF. Acute post-op mediastinitis. This is usually a possible complication of cardiac surgery due to intraoperative wound contamination. Complicate 5% sternotomies, present usually within 14 days post-op. C/F. Fever, tachycardia, chest pain, leukocytosis, and sternal wound drainage or purulent discharge. CXR, widened mediastinum, mostly in non-post-op mediastinitis, but can occur post-op too. DX, clinical and confirmed during surgery when pus is noted in mediastinum. RX, drainage, surgical debridement with immediate closure and prolonged antibiotic therapy. Antibiotics alone do not appropriately treat mediastinitis. Mortality, 10 to 50% even with appropriate treatment. Fib commonly occurs within a few days after CABG and is usually self-limited, with resolution in 24 hours. Rate control with beta blockers or amiodarone is best. Anticoagulation and/or cardioversion reserved if it persists 24 hours after CABG. Pericardiotomy syndrome, C/F, fever, leukocytosis, tachycardia, and chest pain, autoimmune, occur few weeks following a procedure with a pericardium incision. RX, NSAIDs or steroids for inflammation and pericardial puncture if tamponade occurs post-pericardiotomy syndrome, pleuropericardial disease. Occurs days to months after cardiac surgery or injury. Inflammation from surgical intervention can lead to reactive pericarditis, pericardial effusion, or even cardiac tamponade. Pleural effusion can also occur, leading to blunting of costophrenic angles. Most children develop small and self-limited pericardial effusion post-operatively. Infants with larger effusions, abdominal pain, vomiting, and decreased appetite. Older children, usually pericardial friction rub and pleuritic chest pain. Can progress to cardiac tamponade with Bextrade. Tachycardia to maintain cardiac output, CO, tachypnea and dyspnea when CO becomes compromised, RX, pericardiocentesis or pericardiotomy. Retroperitoneal hematoma, H/O recent cardiac catheterization, anticoagulation, sudden onset of hypotension, tachycardia, flat neck veins and back pain suggest retroperitoneal hematoma due to bleeding from arterial access point. Local vascular complications at catheter insertion site, bleeding hematoma, localized or retroperitoneal extension. Arterial dissection, rare, acute thrombosis, pseudoaneurysm or AV fistula. Most hemorrhage or hematoma occur within 12 hours of catheterization. Catheterization, C/F of hematoma, localized discomfort and/or swelling of soft tissue. If puncture site is above inguinal ligament, Hematoma can extend into retroperitoneal space even with minimal visible localized hematoma. Rightward arrow. Sudden hemodynamic instability, ipsilateral flank, or back pain. Diagnosis, confirmed with non-contrast CT scan of abdomen and pelvis or abdominal USG. Treatment, supportive, with intensive monitoring, bed rest, and for fluids or blood transfusion. Surgical repair of hematoma or retroperitoneal hemorrhage is rarely required. Prevention, local hematoma is not uncommon, so PT should be advised to avoid strenuous activity or lifting heavy objects for 1 week. Post-catheterization. Radial artery approach leads to fewer local vascular complications, hence preferred cardiology, GYN/OBS. OCPs and hypertension. OCPs can cause HTN-ESP in PTS with previous H/OHTN in pregnancy. And family H/OHTN, discontinuing can correct HTN in 2 to 12 months. In 5% cases it can lead to overt HTN. Inform the PT regarding risks of continuing and benefits of leaving OCPs plus alternative methods of contraception. If discontinuation does not correct it, go for diet and exercise modification. Helpful ESP in obese PTS. Rightward arrow. If still does not correct, low-dose thiazide diuretics are needed. Mechanism, estrogen-mediated increase in hepatic angiotensin-O-GAN synthesis or other effects on renin, angiotensin system. There is no text on this page. Contents: thyroid gland. 4 hyperthyroidism. 4 thyroid storm.